because the discussion is very important.
discussion is very important واحنا منتظرين نسمع حضرتك عشان نبدا الدسكشن.
طيب اوكي نبتدي. طيب طبعا انا have no financial disclosures to make. Let's start. When you have a fistula, you must have read in the books or maybe in the literature something about advancement flaps. In advancement flaps, you basically take a piece of the mucosa with part of the muscle and you move it and close the hole, the internal hole of the fistula. That's an advancement flap. Another thing is in the past, we used something called fibrin glue. In fibrin glue, we inject inside the fistula. From the external opening, we inject glue made out of fibrin. That's another technique. When the theory behind it, if you inject fibrin in the tract, then hopefully that fibrin will stimulate inflammation and stimulate also some sort of cells, usually the stem cells, and help close the tract. The other thing is a plug. Plug is made of a biodegradable material that is, will degrade with time. And you insert it in the fistula tract, and hopefully, with time, the material will dissolve, disappear, but at the same time, allow the fistula to fibrose and close. Then we have something called lift. And lift, it stands for ligation of intersphincteric fistula tract. So here, you go between the internal sphincter and external sphincter outside the anal verge. You make an incision and you go between them until you have identified the fistula tract between the internal opening and the external opening, and you go and tie it. Tie it on two sides, one side towards the internal opening, another side towards the external opening, and cut it between the two ties. And hopefully, when you cut the fistula tract, hopefully you separated the fistula from the external opening. So the internal opening hopefully will heal, will close, and the external part of the tract will heal and close. Many people now started modifying this technique where they, for example, they close the part towards the internal fistula, but the part towards the external fistula, they laid it open. They, for example, curettaged it, all sorts of things, modified, what we call modified lift procedure. Then we have another procedure called Seton. Seton is an old treatment introduced, or the first time we heard about it from Hippocrates himself. القسم من الطب اللي وضعه أبو قراط. What he did, he used himself to take the tail of the horse, pass it through the internal opening to the external opening, and just tie it. And when he tied it, it cut through the fistula tract. So what you're doing is practically laying open the fistula tract, but gradually, very gradually. You don't lay it open quickly. No, you lay it gradually. And the theory behind it, if you lay the fistula tract gradually, then you give time to the muscle not to be cut immediately and the patient becomes incontinent. You allow the muscle at the same time, while it's being cut gradually by the Seton, it will heal at the same time. Nowadays, we don't use the hair from the tail of the horse. We use silk instead, natural material, of course. Lately, we've been using laser. These laser comes in probes. You insert them through the fistula tract, and you cauterize with the laser the fistula tract. And this way you fibrose the fistula tract and hopefully close it. The only problem with the laser, of course, is very expensive. Then you have the platelet-rich plasma. Platelet-rich plasma is supposed to be a good medium to allow healing. So promote healing. It's rich with materials that promote healing. So you inject it in the fistula tract, and hopefully you promote the fibroblast to lay fibrosis and collagen here, and at the same time close the fistula tract. So let's take the first one. In the I would say early 1990s, in Chicago, Dr. Hernad Abikarian, who was American, originally Armenian, Irani, decided to inject fibrin glue in the fistula tract. And when he did this, he claimed that it is a very successful treatment. And everybody at that time followed his steps. And this fibrin glue was very famous in the 90s, very famous. And you can see here, if you look at the numbers, you can see that the success rate was 85% at the beginning in 1999. Over the this curve in front of you is a classic curve in any new treatment. What happens is whenever a new treatment is introduced, it has a phenomena called the new treatment phenomena. The new treatment phenomena, any treatment when first introduced, will have a high success rate. Then over a period of 10 years, the success rate will drop, and then plateau at a low level. At the level which is the actual success rate of that treatment. And this is very classic to happen. For example, medications, for example, surgeries. This curve is classic. So why do we have high success rate first and then things drop down? Because the first time you introduce a treatment, there is something called investigator bias. The person who invented the treatment is enthusiastic about his treatment. He's biased towards his treatments. He's trying to sell his treatment. So he tends to view every case as a success story and ignore red flags. And how does this happen? So if you go and inject fibrin glue in patients and follow them up for only 3 months, you'll find out within 3 months you've injected the fibrin glue, the patient will be happy, there is no discharge within 3 months, and nobody's complaining. So you'll say this is a success rate. 85% of them are not complaining, 85% cured. You go and follow them up for 2 years, then the fistula comes back and the success rate drops. And you see that the success rate after 2 years is not 85%. In fact, it's much less. Then it's not like you're lying, but because your follow-up was short, you didn't see the recurrence. You didn't see the failures. And the second thing, which is very important, when somebody else tries their treatment, that person who's trying the treatment, somebody else, is not enthusiastic like you. He is trying to show if the treatment is really good or really bad. So he will look for every single, failure. So he will do it for 2 years instead of 3 months, number one. He will listen to every complaint by the patient and consider it maybe a failure. And the others will show you that the success rate is lower. So here, I tried to publish to you from the same center, University of Illinois, Chicago, where Dr. Hernad Abikarian is retired now. What's the success rate of this treatment? So his students, who are now professors, of course, continued to publish about the treatment. And you see, Dr. Hernad Abikarian was very enthusiastic. He gave a success rate of 85. Then his student, 68, then stayed plateaued at 69. Then somebody else, another generation of residents or students, published a success rate of 40%. And the last resident, or now professor, by the way, published 19%. So this treatment is now dead. Nobody's using it. And I'm sure you in the future, when me, retired, and maybe you take over as professors, you will publish that the success rate of a treatment I published will be much lower. because you think, I was enthusiastic about a certain treatment. And in your hands, we will see the true success rate of that treatment. So this is a normal phenomenon you will see and repeats itself. So based on this, if we accept that the success rate is 19%, then the recurrence rate is 81%. Nobody in his right mind can bring a patient to a clinic and talk to him and tell him, I will offer you fibrin glue treatment, and the success rate is 20%, and you have a chance of recurrence of 80%. Nobody will accept it. So this treatment died. So you will read it, by the way, still in the literature, and comes back every now and then. And I think this in front of you should kill this treatment, this option. Cleveland Clinic, this is a famous clinic in the US, and they are the champions of advancement lab. Professor Medbouli, my friend, trained at Cleveland Clinic, and he was not trained by anybody. He was trained by the giant of Cleveland Clinic. Victor Fazio, James Church, Tracy Hall. These are big names, very big names in cort surgery. Victor Fazio, by the way, visited Egypt several times. And at the same time, he was the president of the American Society of Colorectal Surgery. So they were doing flaps for their patients. So they cut part of the mucosal wall with part of the muscle. Which muscle do you think they're cutting? They're cutting part of the internal sphincter muscle, because if you have the muscle, first the internal sphincter, then the external sphincter. So they cut the mucosa, which is lying over the internal sphincter. So, and they move it and cover the internal opening. So when you cut part of the internal sphincter, you expect that, you're giving very rich flap, rich in blood supply. The muscle is the richest tissue in the body with blood vessels. So you hope when you do this that the richness in the blood supply will help heal the internal opening. So again, they published their data, and you can see their data is consistent. So they introduced it in the 80s, and the success rate was 69%. Then again, in the 80s, 71%. Then when you go to the 2000s, it drops to 64%. Then again, the residents, it's not showing, but in the 2010, I think, you can see the reference. I put the reference, but here it is. Well, let me move in 2006, yes. In 2006, it went to 50%. So if you want to offer this treatment to a patient in the clinic, and let's say you are doing a private case, and you're telling the patient, I want to offer you an advanced flap, the success rate is going to be 50%. The patient probably will not accept it. I mean, he's going to pay some money, and the chances he will be cured is random. 50, perhaps yes, perhaps no, 50%, right? So that's the treatment that's, the advancement flap, which is, not very impressive. Now keep this number in your mind, 50%. Now the other thing which is very important, is the recurrence rate. Recurrence rate from their studies, latest one, is 49%. So can you sell it to the patient? It will be very difficult to sell it to the patient. So if you want to use this treatment, there must be an indication for it in certain situations. I'll give you an example. So if in certain fistulas, the options available to you are limited, and I will go over them in the end, then maybe advanced flap is the choice in that case, although it has a low success rate. So this is where you are forced to use it. Maybe, for example, I'll give you an example. In a lady with a rectovaginal fistula. A lady with a rectovaginal fistula, you you cannot, for example, do a fistulotomy, because if you cut between the internal opening in the rectum and the external opening in the vagina, you end up with a cloaca. You end up opening the vagina to the rectum. You cannot do this kind of treatment. You cannot do a lay open. An advancement flap would be a good choice in a rectovaginal fistula. So, although the success rate is not very high. Okay. One of the things used by Cleveland Clinic when they first introduced the flap is that they talked about the fact that the flap will avoid the fistulotomy, because fistulotomies can cause incontinence. So when they do a flap, they're avoiding incontinence. But the studies are not supporting this. If you think again about it, in a flap, you're moving a mucosa with part of the internal sphincter. If you move part of the internal sphincter, you're cutting it and moving it to cover the internal opening, then you're cutting part of the internal sphincter. Then you must cause some sort of incontinence. You must cause some sort of incontinence. So, and the claim that advancement flap doesn't cause incontinence is not true. Well, the studies proved it. You look here, you see that there is something called major incontinence and minor incontinence. You see the minor incontinence ranges between 10 to maybe 15%, and the minor incontinence between 10 to 15%, and the major incontinence between 5 to 10%. What do we mean by minor? Minor mean incontinence to gas, seepage of fluid, leak of fluid, yellow stain in the underwear. The major incontinence means that he's leaking stool, liquid stool, or solid stool, and that's 5 to 10%. That's something you must keep in mind when you do an advancement flap. Now, if you keep this in mind, you expect those patients, when you do manometry on them, you expect prior to the surgery and after the surgery, you expect the resting pressure of the internal sphincter to drop after the surgery because you cut part of it. And you need to counsel the patients about this. Very important. So when you do advancement flap, when you take the consent, you need to tell the patient about this. About, I would say, 10 to 12 years ago, a surgeon from the States, who was not academic surgeon, he in collaboration with a company, introduced the plug. So they took a biodegradable material that degrades with time, rolled it, and used it as a plug. They introduced it into the internal sphincter to plug it. And they published data showing that the success rate was very high. The success rate was around 87%. Everybody was mesmerized. Everybody thought this is the treatment of the fistula. Finished. We have now a treatment for fistula and anal. So I remember the second article published about this came from Saudi by my colleagues, Dr. Omar Labeid, Ahmed Zbeidi, from King Saud University, where they had, I think, 20 patients, or which is at that time a good number, because not many people were using this, just introduced in the market. And they published it, and they showed the success rate is similar to the American surgeon. Success rate is about 83%. So you can see here in this curve, I'm not plotting the success rate. I'm plotting the recurrence rate. So if the American surgeon had a success rate of 87%, the recurrence rate was 13%. If the Saudis had a success rate of 83%, then the recurrence rate is 17%. Then more articles came in large numbers, and the success rate increased. The success rate dropped to 20%. The recurrence rate 80%. 80%. Recurrence rate 80%. And this means that if you go to the patient and tell them, I'm going to put a plug, and I expect that it will have a success rate of only 20%, a recurrence rate of 80%, failure rate of 80%. I don't think any patient will accept it, especially it's not cheap treatment. The material that you use as a plug is a biological material. So this is again another curve repeats itself of what we call the investigation bias curve, the treatment first treatment curve. This is what you see, the bias, again, like the one I introduced for the glue. Now the company that produced the plug stopped producing it. They pulled it out of the market. Why did they pull it out of the market? Because the patients will sue them for failure. So it's not available anymore. So that's another issue. I'm highlighting another treatment for fistula has been introduced and has a recurrence rate of 80%. When you see so many treatments for fistula, then you wonder to yourself, why are we having so many treatments, so many options? This means one thing, we don't have a curative option yet. We don't have a treatment where we give to the patient and the success rate is 95%. We don't have this treatment yet. So that's why we have so many options. We're still in the trial phase, trying to find the treatment that will cure the fistula. We're unable to cure it so far. So everybody gave up on the plug because of its recurrence rate. Then a surgeon, his name is Arun from Thailand, he introduced what we call ligation of intersphincteric fistula tract. And he published about it in his local journal. It's an intelligent treatment, very intelligent treatment, because he's not cutting muscle. So there is supposed to be, by theory, no incontinence. Number one. Number two, he's not going through the tract itself, causing any damage, So that's another issue. And third, he's going outside the anal verge, between the internal sphincter and external sphincter, and ligating the fistula tract. And he had a success rate. If you look at the curve, he had his first publication there, he had, I think, success rate of 94% and a recurrence rate of 6% only. Well, he's not the one who popularized the treatment. The one who popularized the treatment is another surgeon called Stanley Goldberg, who is well-known internationally. He was the president of the American Society of Cardiac Surgery. He used to travel a lot. And one day he was in Thailand and he saw the treatment and he was mesmerized. He was asking himself, why didn't I think of this treatment? So he's a professor. So he immediately went back and did a multi-central trial of the treatment. So he asked many centers to try the treatment and report to him to publish about it. The first article came back with a success rate of about, I think, 82%, which was the first study. Then came back another study with a larger number, longer follow-up. The follow-up is very important in fistula because as you increase the follow-up, you'll see more recurrence. And the success rate dropped to around 62%. Recurrence rate is about 38%. So you'll see here I want to remind you, when we talked about the advancement flap, success rate 50%. The lift procedure, success rate is 62%. They're close. Close, huh? So the success rate hovers in the 50-60 range, 50-60. You will see it in many other options. But when you go and treat patients with very complex fistula, or somebody who has a recurrent fistula, somebody had a recurrent fistula, and you try to use the lift procedure, the recurrence rate is much higher than 38%. The recurrence rate is 54%. So it drops and becomes like an advancement flap. The recurrence rate is 50%, like an advancement flap if you're dealing with a complex fistula or a recurrent fistula. So again, the success rate, hovers in the 50-60, and the recurrence rate, as you see here, in the 40-50%. Keep this in mind. Now, there was a treatment which, when I trained in the States, was dead by the group where I trained at, which is called the Minnesota University Group. The Minnesota University Group used to use a treatment called Seton. The Seton, which I explained to you a minute ago, was invented by Hippocrates, and he used natural material like the hair from the tail of a horse. Now we use silk, of course. But Minnesota did not use silk. They used other materials. Anyway, they had a problem with it. When they used it, the Seton treatment should not have high incontinence rate, should be low incontinence rate, because you're cutting the sphincter gradually. If you think this is the sphincter, and you're cutting with the thread, the sphincter fibers, these are the fibers. So first you cut the first fiber, and then you cut the second fiber. And because the sphincter is still intact, it's not disrupted, the first fiber will heal, and then the third fiber is cut, the second fiber will heal, and then the fourth fiber will be cut, and the third fiber will heal. And the thread will fall off the anus, will leave the anus, and the fourth fiber will heal. And therefore, you maintain integrity of the anal sphincter. It doesn't disrupt. Like when you do a fistulotomy, it becomes like this. It never heals because the gap is too big. So in this case, it's baffling. They had an incontinence rate of 45-66%. And they published 3 articles about it. And they're honest. This is very important. They did not hide the information. They said, we tried it, and we had a high incontinence rate, 45-66%. And these are the publication in the 90s. You can see them here. I joined them after that period, and these are the publications. So they decided not to use the Seton anymore. However, if you go and look at the Seton with a systematic review, a systematic review, what you do in the systematic review is take all the data published about the Seton, randomized trial, clinical trial, take the samples, add them together, all of them, and then calculate the total success rate for the whole published articles. If you do this, there are 19 studies with a total number of 448 patients. The success rate is 95%. And incontinence rate is 5.6%. So we have 19 studies which shows a very low incontinence rate. So the incontinence should be low. Why should it be high with Minnesota group? That's confusing. There must be something, abnormal. So somebody need to look at those articles. Anyway, I will touch on it in the second part of the presentation. Laser closure, it's very expensive. It's been introduced recently over the past 5 years. The probe is not cheap. In Saudi, it's about 15,000 riyal. I would presume it's very huge price in In dollars, I would say $4,000. So I think you multiply it by 50, you take about 200,000 pounds, Egyptian pound. That's very expensive, in my opinion. You look at the data, 2017 systematic review, 2020 systematic review, 7 studies, 8 studies, that's a good number. Number of patients, around 450, 470. Success rate is consistent, 60, 67, 63, so in the 60s. I want to remind you, the advancement flap, 50, the lift procedure, 50, 60, and the laser, 60, so all very, very close. And the follow-up, the first one is about 2 years. The second one, variable, so they were not consistent. They couldn't give you an average number. Complication is around 8%, acceptable. So if you think about it, you're paying a very high price for a success rate of around 60%. Should you do it? You could do an advancement flap, or you could do a lift procedure, much cheaper. Too much of a burden on the patient. Platelet-rich plasma is not cheap also. Less expensive than laser, but expensive still, because you have to prepare this through a certain device. Again, there are 9 studies 2020, 14 studies 2023. We're talking about trials, clinical trials, huh? Number of patients, 289, 2020, 2023, 500 patients. Again, success rate, 65% or 62%. So again, consistent, 60, huh? Around the 60s, same. Should you pay that high price for a success rate of 60? I mean, if somebody tells me the success rate is 90, maybe I'm willing to pay the price. But this is the same, okay? The same usual 60 with the other procedures. Recurrence rate is about 12%, 15%, you know, not very high. But again, the success rate is not, you know, does not make me, you know, does not push me to go and pay that price to do it. I think the algorithm, if you think about it, if you think about when you think about fistulas, there are treatments which you see in the first line, which is platelet-rich plasma, fibrin glue, plug, lift procedure, laser. They have one thing in common, all of them. In all these procedures, you're supposed not to cut the muscle. You're supposed just to, you know, introduce something in the tract or cut the tract, but not cut the muscle. Therefore, incontinence rate should be very low. Should be very low. And this means that the intersphincteric plane is not being touched. You haven't touched it. You haven't dissected it. So in that case, you can do a lift procedure, for example, in the first choice. Now, let's say they failed. All these procedures failed. But what should you do? Go ahead and put draining Seton. What's a draining Seton? You just put some sort of vessel loop or put a thread, simple thread like silk, loose silk, you know, number 2, and leave it loose, not very tight. And then you can refer the patient to a colorectal surgeon. Because once you have a recurrence, it's not something to be dealt with by a general surgeon, just to be dealt by somebody expert in this field, the colorectal surgeon. Because the second type of procedure, there is chances of incontinence. There is chances of legal, you know, issues that the patient may go to court. Okay, so you don't want to go into this at all. So you need to refer him to a specialist, colorectal surgeon. That's number 1. If you want to deal with it, then you have 2 choices. You can do lift. You can do a second lift, we call it. Try your luck. Or can do what we call a cutting Seton, which I will touch in the second lecture. But let's say patient comes to you where he did a flap. In the flap, you have interrupted, the anatomy of the fistula, or you did a fistulotomy, which means you cut the sphincters to lay open the fistula tract. Again, you disrupted the anatomy. Or you did the lift procedure for the second time, disrupted the anatomy. So you have really did not preserve the intersphincter plane. Intersphincter plane between the internal sphincter and external sphincter is not virgin, has been disrupted. Again, you put the draining Seton. Draining Seton will get rid of the sepsis, the pus, the tissue edema, tissue inflammation. Things will settle down. Patient will be happy. Things will really settle down. He won't see much pus after maybe 4 weeks. The pus will be minimal, very minimal. Okay? So in that case, you should, after you put the draining Seton, either refer him to a cardiac surgeon, or if you have experience, you can use the cutting Seton. This is the first part of the presentation. Maybe we can take questions before I go to the second one, or you want me to continue with the second one? It's up to you.
الحقيقة very good, interesting and very interesting presentation, Professor Nasser.
شكرا.
أنا ليا سؤال بس علشان الشباب يبقوا مع حضرتك. هم خلاص كده حضرتك اديتهم بانوراما على ال different types of treatment of أو surgical treatment أو medical treatment أو conservative treatment of fistula.
صحيح.
If we are classifying the fistula into two parts, the low fistula and the high fistula, what is your management preferable to Professor Nasser?
طيب ودي ادخل شويه بالديبيت حق الكلاسيفيكيشن. طبعا انت when you go to the books, they give you what we call Sir Alan Park's classification of the fistulas. In real life, what matters in the classification is not what you see in the books. What matters in the classification is two things. If you know the type of the fistula, it may direct you to a certain type of treatment, certain option. I will touch this in a minute. And the second thing is, if you know how much the fistula is going through the muscle, it will dictate to you how much muscle will be cut. And if how much muscle will be cut means incontinence. So if we take this from history, Sir Alan Parks, when he did the classification, he did not have CTs, he did not have MRIs. So the classification he did was based on fistulograms and was based on intraoperative findings. Nowadays, we classify the fistula by MRI. Different approach than Sir Alan Parks. Number one, because when we do the MRI, we can know the tract, how it's going. Some of these MRIs are not helpful because the radiologist is not describing things in a way that helps you. So you need to look at the images yourself. Second, the classification of the type of the fistula. So if you have intersphincteric sinus, for example, which means an internal opening in the posterior midline that goes into an abscess cavity between the internal and external sphincter. And maybe has an external opening in the intersphincteric plane. How do you treat with this case? In such situations, you do only internal sphincterotomy. Only internal sphincterotomy. Once you've done it, you open the fistula tract, which is contained within the intersphincteric plane. Finished. And this is rare. You don't see many of these cases, by the way. Most of the cases that you see are fistula are usually transsphincteric fistulas, where you need to lay open the fistula tract. And I myself think MRI is not needed for every fistula. The MRI is needed only in cases where you failed for the first time or you suspect a complex fistula. You need most of the time you need to examine the patient in the operating room, decide after you probed it how much muscle will be cut, and that will decide should you do, for example, fistulotomy or not. If the muscle is too much that will be cut, more than 30%, then you need not to do a fistulotomy. And when we say 30%, people define it differently. What does 30% mean? Some people use different ways. I define it is you put your finger inside the anus and you hook the sphincter from inside and you define the length from the anal verge to the upper end of the sphincter. You can cut only up to 1/3 of that length. That's number one at the length level. The width is also from the anal verge to the outside of the anal verge. You can feel the sphincter, and that length you cut only 1/3 of it. And this way you're cutting 30%. So based on this, in my opinion, the classification from certain Allen Parks is not practical at all in real life scenarios. The MRI is, again, the way it's read most of the time is not helpful. And you need to examine the patient yourself, measure the length yourself, measure the width yourself, and decide on the 30%. If it's above that 30%, you have to decide on a different option other than fistulotomy. Any other questions?
I think we will complete discussion after the second part of your talk.
Okay. Let me go. A minute. Can you see the slides?
Yes.
Okay, good. So now we went deep into fistulas, treatments, options. I discussed the history of each treatment, success rate, recurrence rate. Again, I'm reminding you, we talked about the advanced lab, success rate is around 50%, and you have to use part of the internal sphincter to use it. You cannot use mucosa only. Mucosa only will necrose in no time. You have to use thick flap. Fibrin glue is dead. Nobody's using it. So if you keep reading it in the literature, there are people who are, keep hanging to it, but it's practically dead. Nobody's using it. Plug, companies are producing it. And another company introduced another plug later on. Again, I think pulled it. And there are surgeons who themselves make a plug. So they take, the hernia biological mesh. They take a piece, they roll it as a plug, insert it. Some also go and modify technique. They like a lift procedure. They go and cut in the intersphincteric plane between the internal sphincter and external sphincter outside the anal verge. They go and they ligate the fistula tract, and then they put biological mesh. These are variations of the plug, but these are, and each one of them reports a very high success rate. I myself haven't seen real good clinical trials on this. And I believe any foreign material put in an area where it's dirty, fistula tract is dirty, by the way. It's next, bringing stool, is usually does not have a high success rate. And that's why this plug failed. Then the lift procedure. Lift procedure is working nicely if you abide by the principles of the technique. But people tend to modify it. They introduce, as I said, the mesh, biological mesh, or they go and, for example, do some cutting of the muscle with it sometimes, and they end up with incontinence. So a lift procedure, by theory, should not cause incontinence. But if you look at the literature, you'll see cases of incontinence in the range of about 5 to 10%. And that's because they modified the technique. Seton is there. It's a time-honored procedure. Some people hate it because, as I told you, because they had a very high incontinence rate with it. And I will explain the situation with this. Laser, success rate is around 60%, consistent, however, very expensive. Recirculated plasma, again, success rate around 60%, expensive. And then let's look at these procedures and let's look at the recurrences. These are the procedures in front of you. And what I want you to look at is there are procedures that don't cause incontinence, and there are procedures that cause incontinence. Anything that cuts muscle, suppose to cause incontinence. Fistulotomy will cause incontinence. Seton will cause incontinence. Lift, if you go and do modification to it, will cause incontinence. Anything that does not cut the muscle should not cause incontinence. Glue, plug. But the flap, they claim it doesn't cause incontinence. I showed to you that it causes incontinence. There is element of incontinence with the flap. Another important thing, these are, the recurrence rates, and you see the recurrence rate is very high for the plug, up to 95% recurrence. That glue had a success rate of 85%. Now, the recurrence rate completely reversed, 95%. So if you wait on a procedure, you will see with time that it has failed. And this is a classic. Many procedures like the Bitcoin. Everybody wants to go into it, and then all of a sudden, it crashes. I think when you think of the situations, it affects your decision. For example, if you have a healthy subject who has a fistula compared to a Crohn's patient with a fistula, what should you do? These are two different scenarios, and the choice here is different. I'll explain it here. What you'll see, in a healthy subject, you could use a cutting Seton, for example. But in Crohn's patient, you cannot use it. You will use a non-cutting Seton. You just put a vessel loop in a Crohn's patient. So in this case, in the Crohn's patient, we didn't use fibrin glue, we didn't use a plug, we didn't use laser, we didn't use rich plated plasma, we used a non-cutting Seton. Just a loose Seton, whether you want to use vessel loop or silk, it's up to you, just to drain the pus. Why do we do this? Because Crohn's, if they develop a fistula, they will develop more fistulas and more and more and more fistulas with time. And the fistulas is not an issue of just a fistula, it's an issue of active disease. So you have to treat the active disease. You have to give biological treatment if you want the fistula to heal. It's not surgical treatment here. The treatment is medical treatment. So you have to tell the gastroenterologist, if you want me to remove this non-cutting Seton, I want you to give him biological treatment to the point that his Crohn's become quiescent, becomes inactive, And how do you prove it? You scope him, you see that the rectum is completely normal, no ulcers, no telangiectasia, and at the same time you look at his ESR, you look at his CRP, and you see all of them are normal. You calculate his Crohn's activity index, and it is low, below 200. Then you say, okay, this patient, his Crohn is under control. You do MRI, and you see there's no inflammation around the fistula. Then you say, I can give him a trial. I can remove the non-cutting Seton and see what happens. And in 30 to 40% of patients, the fistula will close on its own because the medical treatment worked. In the old days, they used to give them long-term treatment of flagell, but it's not the, nowadays it's biological treatment. Another important issue is when you go and treat a patient, you ask yourself, do I want to give him incontinence? If somebody comes to you with history of incontinence, definitely you will not choose any procedure, any option that will give him more incontinence. So if somebody comes to you and had a flap and he's incontinent now, definitely you will not use a procedure where you will give him more incontinence. You will not use the flap again, for example. You will not use a fistulotomy for sure. So these issues will dictate your decision on the fistula. So you ask yourself when you see a patient, is he healthy? Does he have Crohn's? Number two, does he have a history of incontinence? If he has history of incontinence, certain options I will not give to him. I will try to use options. Yes, the success rate is low, but at least I will not give him more incontinence. See my point? So you're forced here to give him a lower success rate and avoid problems. Now, another issue is, if you think about it, there is the non-cutting Seton and the cutting Seton. Non-cutting Seton, of course, no incontinence because you're just draining him. The cutting Seton, there is incontinence, risk of incontinence 5 to 10%. So in a cutting Seton, you should ask yourself, if somebody comes to you, he failed treatments, all sorts of treatments. He used, for example, laser. He used rich platelet plasma. He used, for example, lift procedure. He used a flap. You have nothing left except the cutting Seton. So you're forced. Then you have to counsel him and tell him, I can use this technique. There is a chance of 5 to 10%. What kind of incontinence? Usually it's minor incontinence, which means gas, minimal gas, and maybe seepage of yellow stain. And you have to tell the patient. It's up to you. Another issue, so these are decision-making issues here. What type of Seton should you use? Should you use number 2 silk? Should you use a vessel loop as your drain or as your Seton? Well, if you are using cutting Seton, you should use the silk. If you're using a non-cutting Seton, I think you should use the vessel loop. I've seen people use the silk as a non-cutting Seton. They have it loose. Or use Ethibond. I don't like Ethibond because Ethibond is an artificial material. It's like polyester. So, but I think classically, non-cutting Seton is a vessel loop, and a cutting Seton is number 2 silk. Let's go back to the issue which I discussed with you. Why did Minnesota group have issues with their Setons? Again, remind you, they had incontinence rates is about 45% to 66%. And these are 3 articles published by a group. They were honest. They published it. They said, we have incontinence with our Seton. Most people don't write these, bad results. They wrote it, which is, admirable, by the way. So people are afraid to write about their, failures. And they're afraid if they write they're having cancer 5%, they think other people will think they're not good surgeons, but they did it. Well, if you look at their studies, and these are the studies, you find out a few things they made. Number one, they did not use as a cutting Seton this silk. In fact, they use Penrose drain, plastic, or rubber band that's used for tying the hemorrhoid. If you use rubber band or use Penrose, it's very wide. And if it's wide, then what happens, it cuts part of the muscle, wide part of the muscle. Second, because you're using inert material, not latex, then there is no fibrosis. So the muscle is cut and there is no fibrosis. It doesn't heal. And the result is incontinence, 25%. Other issue, they tightened the Seton quickly. They put it during surgery and then tighten it in less than 3 weeks. If you tighten it very quick in less than 3 weeks, so you bring the patient, for example, after the surgery, after a week, you tighten it, and then you bring him after 2 weeks and tighten it, you don't allow the muscle to heal. You're practically just cutting the muscle, not allowing it to heal. It takes weeks for the muscle to heal. And the incontinence rate is 63%. So do not tighten the Seton very fast, less than 3 weeks. Other thing, they didn't do Seton surgery alone. They combined it with another procedure. For example, they did a Seton plus internal sphincterotomy. Well, if you did internal sphincterotomy, you already caused incontinence to gas, definitely, and seepage of stool, and that's 20% incontinence. So this you should not do this. That's a cause of incontinence. And erectovaginal fistula, you cannot use the Seton whatsoever. Why? Because as I said, once you open between the rectum and the vagina, you have a cloaca. So if you do a fistulotomy, you do a cloaca. And if you use a Seton, you're practically doing cloaca also. So never use a Seton in erectovaginal fistula, because the chances of incontinence is 50 to 100%. So that's why the Minnesota group, when they used the Seton, had the high incontinence rate. So you cannot really accept articles and say, Minnesota group, which is a prestigious group, had high incontinence rate, I shouldn't use the Seton. You should dig deep and find out why did they have it. We published our experience. By the way, this is at that time when Minnesota said Seton is dead, everybody killed the Seton in the 90s. I finished my residency and fellowship, and well, in the States, the colorectal is a residency, not a fellowship, called American Board of Colorectal Surgery, I think. Yes, residency, not a fellowship. Anyway, I finished and I went back. I myself was using, at that time, because I was trained in Minnesota, I was using the flaps. And I saw my surgeon in Riyadh at King Faisal using the Seton. He was trained at Cleveland himself. And I asked him why he's using Seton, and he said high success rate. I said, well, in Minnesota, said it's very low success rate. He said, why don't you take our data and publish it and see what's, if our data is bad. So I went, collected the data. At King Faisal, we accept only recurrent fistulas, only recurrent complex fistula. So simple fistulas are not accepted. So these are fistulas that have been operated outside maybe 2-3 times and failed and came to King Faisal, and 47 of them, and they had a Seton. Success rate was 98%. His recurrence rate was 2%. He had a good follow-up of 1 year. Incontinence rate 9.5, and presumably incontinence is due to the surgery done prior to the Seton. So that resurrected the Seton again. So once it was published in Disease Colon Rectum in the US. And again, systematic reviews showed up, the ones I showed to you, similar to us, 95%, about 450 patients, 19 studies came. And this led to that the American Society of Colorectal Surgery introduced clinical practice guideline for fistulas and cited our article. I published an article with my professor at that time. He was the chairman of the department. And they cited our article. And they wrote, a cutting Seton may be used with caution in the management of complex cryptoglandular anal fistulas. So it came back as an option in fistula and anal, and according to the American practice guidelines. So if we go to this, then if you have somebody with Crohn's, you want to operate on the patient with a procedure, but you don't know what's the procedure. You want to plan a procedure, but still you don't know what that procedure is. You want to provide treatment, temporary treatment for the time being, then the best option is to do a draining Seton. When you put a draining Seton, you drain all the pus, you remove them, help cure the infection, the edema. The tissues will be much pliable, and then decide on the second stage. You can convert the draining Seton into a cutting Seton if you want, down the line, if you want. You can, of course, if you are sure that you want to use a cutting Seton, you can jump to it from the beginning, because a cutting Seton itself is a draining Seton. So that's the conclusion. I think I finished and open for discussion.
First of all, very thanks, Professor Nasser. All of us very interesting and very pleasure to hear you in this very good topic. And your presentation is discussing a lot of debates about incontinence and also about the recurrence rate, which is the two night dreams affecting every surgeon. في سؤال لحضرتك يعني بيقول لحضرتك incontinence is the result to the surgeon, complexity of the fistula, or patient factors, or mix of it.
Incontinence?
Yes.
Inconsistency in the result can be attributed to the surgeon factor, complexity of the fistula, and the patient factors. There is very inconsistent. مفيش اتنين استادي متفقين، على الأغلب بيبقى فيه variety في الريزلت.
Let me analyze it in a different way. Any fistula does not cause incontinence. A fistula itself does not cause incontinence.
Yes.
The incontinence is an iatrogenic event caused by the surgeon, definitely, by the surgeon. So, and it is the result of how much muscle was cut by the surgeon, depending on the option he used. And this is very important because I'm an advisor for the courts, and it is important if you want to use an option, and there is element of incontinence because of that option. It's important you inform the patient and include it in writing in the consent. And in writing, I mean you write that I offered the option to the patient, والخيار في احتمال عدم التحكم في الريح، في البراز السائل أو البراز الصلب، أو تسرب في المخاط من فتحة الشج اللي هو fecal seepage أو تسرب البراز. You have to write it and let the patient sign on it. في القضاء they want to see this in writing. المحامين بالذات they don't are not satisfied unless they've seen it written. And the fistula is I would say big thing for the lawyer to win, easy to win, because the surgeon, he writes and the complication of the procedure was explained to the patient. It's not enough for the judge and not enough for the lawyers. Now, incontinence is caused by definitely the surgeon. If the patient was informed and the patient signed on it, okay, done, finished. Patient knew about it, knew about incontinence and signed on it. Now, which option should you use is also another issue. So I would write myself وعرض عليه الخيارات التالية 1 2 3. المريض اختار هذا الخيار. هو اختار هذا الخيار. خاصة إذا الخيارات مثلا advanced flap, fistulotomy, اكتبهم. It's very important. Now, could the case of the patient be attributing factor in the incontinence? I think if the patient had a prior procedure, for example, had a fistulotomy, but he did not have incontinence symptoms, the moment he has a second procedure, he will have incontinence symptoms because his reserve of the sphincter, he has a reserve of the sphincter. يعني عايش قشة على أنه he will not have incontinence. And he had so much cutting, 30% of the muscle was cut and still not incontinent. The moment he cut more, he'll be incontinent. You see my point? So those patients who had surgery before at higher risk of incontinence should be written in the consent. ويقال أن المريض هذا عمل عملية سابقة مما يجعله عرضة أكثر لعدم التحكم في البراز. I would pay attention to this and write it. التعويض بالنسبة للإنكونتنس ترى عالي في القضاء، يعني في الشرع الإسلامي أو في القضاء عموما، يعني مو منخفض، عالي، لأن it's a lifelong disability.
اوكي بروفيسور ناصر. دكتور محمد صلاح له سؤال عند حضرتك. During drainage of perianal abscess, if internal opening detected about 4 centimeters from the anal verge, do you prefer to deal with it or only drainage?
No, I will only drain the abscess. I will not deal with the fistula at the time of the abscess. Cook County, which is a hospital in the US, produced a paper, 5,000 patients, 5,000. This is a big hospital in Chicago, where they showed if you deal with a perineal abscess, only the chance that you will have a fistula is 30%. يعني 100 abscess, you just drain the abscess, you fold them up, 30 of them will have fistulas in the end. If you do a fistulotomy at the time of the abscess, the chance that those patients will have a recurrence is 70%. So how much was caused by the surgeon? 70 minus 30, 40%. So the surgeon himself caused 40% more fistulas with doing surgery during the abscess handling. So I would not do anything during the abscess drainage. Only drain the abscess.
Okay. When to consider covering colostomy?
You rarely need a colostomy, honest. And if you need a colostomy, it would be in a patient who has Crohn's disease, who has multiple fistulas, and you want to help him heal the fistulas and have a good quality of life. Because having so many fistulas, you cannot even sit. You cannot even have normal life. So we rarely do stomas. You know, stoma is something really devastating to a patient in terms of quality of life. So, and even for Crohn's, we rarely do it. So a stoma is really a very, very, very rare option to be done. And if you've done it, you probably would do it for a patient with what we call perennial Crohn, patient who has disease, Crohn's even in his skin of his perineum. So it's very rare.
Okay. What can you do if you don't see the internal opening intraoperatively?
Oh, yes. So this is very common. So I go in, I have an external opening. I cannot find the internal opening. I don't cut. I don't create an internal opening. By the way, the internal opening should be at the dentate line. Should be at the dentate line. If you see an opening above the dentate line, it was not caused by the fistula. It was caused by another surgery. Ignore it. Go and find the opening at the dentate line. Because we believe, according to the theory, we call the cryptoglandular theory, that all fistulas start at the dentate line. They are these are glands at the dentate line, and these glands are similar to the sebaceous glands around the nipple. They produce material which is characteristic to that individual, has a certain smell. And in the animal kingdom, for example, I'll give you an example. In the lion, the lion goes and excrete this sebum from his anus to mark his territory. And therefore, no lion would come in to that area. Only and the harem or the lioness living in that area will not be attacked by other male lions. So in the case of humans, they lost their function. However, they exist. The opening of that gland gets blocked. When it gets blocked, and the sebum collects inside it, it gets infected and becomes an abscess. The abscess will have to drain. It's either it will drain into the area of least resistance. Usually, if the gland is transsphincteric, which means the body of the gland is outside the external sphincter, you will see it draining through the ischial tract in the skin. Or if the gland is short, you will see it draining in the intersphincteric plane, becomes intersphincteric fistula. So always look for the internal opening at the dentate line. If you don't find it during the surgery, I would put just a drain in the external opening. Now, there are specific drains for the external opening called Debetzer drains. Debetzer catheter. Debetzer, D as in Delta, E small letter, then space, Betzer, P as in pen, E, double Z as in zoo, AR, Debetzer catheter. It's like a mushroom catheter, but it's not a mushroom catheter, it's different. You cut the top of it, becomes like qum, and you introduce it in the external opening. And then the patient, you leave and you don't even, those Debetzer catheters, you don't need to stitch it. Once you introduce in the fistula tract, because they're like qum, yafresh, it does not come out. So, and then you send the patient after 2 weeks or for a fistulogram. I usually wait 3 weeks. And after 3 weeks, you will do a fistulogram to find out if he has an internal opening. Usually because of the edema, because of the inflammation, you cannot find the internal opening. So you need to wait. If I did the fistulogram after 3 weeks, I cannot see it, I'll wait longer and give him another 3 weeks. Repeat the fistulogram, and by that time, when I feel the patient the external opening, is it soft, it's pliable, tissues, the edema has subsided. Most of the time, when injected, you will see when they inject the contract, they will see in the internal opening, and then you bring them back to the operating room, and you probe it. Now, let's say you don't want to do a fistulogram, you put the drain, you do an MRI. And when you do the MRI, you do it with contrast. You have to do it with contrast because they will identify with contrast the internal opening. They can inject contrast, by the way, and find the internal. That's if you have a good radiologist. But you need to talk to the radiologist. You need to inject goldonium contrast to see the internal opening. Again, I would wait longer before I do it, because with the inflammation, he will not see the internal opening. You need to wait 3 to 6 weeks before you do this study, and you will find it. Most of the time, you find it. Most of the time, you find it. You just need to wait. But I would not do anything blind.
Okay. What do you think about the rerouting of the fistula tract?
Rerouting. What do you?
Yes.
Rerouting. Maybe he can explain to me what does he mean by rerouting.
A lot of surgeons can reroute the tract from intrasphincteric, from suprasphincteric into intrasphincteric, to change the site of the fistula.
If you accept that all fistulas are starting at the dentate line, then you don't need rerouting, because the fistula should start at the dentate line. If you think about, if this concept of high fistula, low fistula, the high fistula has been caused by the surgeon, not by the human body itself. That opening up, in fact, you don't need to deal with it. You need to deal with the opening at the dentate line. If you deal with that opening at the dentate line, you have, I would say, you have killed the head of the snake. The head of the snake is at the dentate line, and the internal opening up will dry because nothing is feeding it. Once you've dealt with the internal opening at the dentate line, that part of the fistula, which is the extension above that dentate line, will die by itself. You don't need to deal with it. So people come to me and say, okay, we have fistula which is extending from to the right to the left, extending above the anus, extending up to the mid-rectum. I tell them, look for the fistula internal opening at the dentate line. Deal with it with a Seton, for example, and all these other tracts will heal by themselves. You can, if you want the extrasphincteric part of the tract, extrasphincteric, which means the part of the tract in the fat outside the sphincter, you can lay it open if you want to, okay? But don't cut muscles. We need to avoid cutting muscles as much as possible, and those will die. Once you've drained the fistula itself, the head of the fistula, which is the internal opening, with the drain, with the Seton. But the Seton is a drain, by the way. Just the thread, even loose, is a drain. Once you've dealt with it, then the rest of the tracts will heal, by themselves will heal. And you see all these surgeries on YouTube of surgeons cutting all the way up to the abdomen, cutting all the way over. Really, you don't need this if you just dealt with the internal opening.
Okay. If we cannot dissect the tract, can we do lift surgery is enough?
If you cannot dissect the tract, you cannot do a lift procedure.
Yes.
Because in lift procedure, you have to dissect the tract and encircle it and then tie it on both sides. If you cannot do it, you cannot do a lift procedure. And that happens, by the way, in a patient where somebody did the lift procedure before you. or somebody who did, for example, an advanced flap. That plane is completely disrupted, fibrosis. You cannot do it. Then you have to think of other options.
Okay. The fistulogram is informative enough in a pre-operative assessment, especially if MRI is available.
I think the aim of the fistulogram here, whether you want to do it, you're doing a fistulogram, either you want to do it with the contrast, like water soluble contrast, or you're doing a fistulogram MRI. Fistulogram MRI. The aim is to find the internal opening. Whatever is available to you and cheap, go ahead and do it. I'm not insisting on any one of them. You just need to do which is, you're doing things out of pocket. Patient is paying. If insurance is paying, fine. The MRI is expensive, not cheap. So if you want to do it out of pocket, whichever is cheaper, available to you, go ahead and do it. I'm not insisting on anything. The aim is only to find if there is an internal opening or not. Once you found the internal opening, you're going to take him to the operating room and you're going to probe it. And with the probe, you identify the tract.
اوكي. احنا سهرنا حضرتك معانا، وانا عارف
ناخد
ان
راحتك.
الميعاد في المملكه دلوقتي الساعه 1 الا تلت.
ساعة صح.
ف
ابراهيم يعني
احنا
دكتور ناصر
متشكرين
عادة
لحضرتك
في الوقت
جدا
زي ده
بروفيسور ناصر.
بيكون نامه صحي.
مش كده؟
انت
بس
فاكرني
انت
بهزر يا ابراهيم؟ انا مش
سهير يا
بهزر،
خالد يعني.
انا قديم.
دكتور ناصر، احنا مش عارفين نشكر حضرتك ازاي يعني. الحقيقه الناس مستمتعين جدا
شكل الحضور.
وكلهم بيشكروا حضرتك. وفي عندي يعني كذا حد كتير جدا من الزملاء باعت لحضرتك شكر خاص على البرزنتيشن، يعني هم استمتعوا فيه، رغم ان في ناس سمعوا السيشن مع حضرتك قبل كده في المؤتمر بتاع خالد، ولما سمعوها المره الثانيه استفادوا اكثر الحقيقه.
الحمد لله. واذا تبي راح ارسل لك اياها على الواتساب.
طيب، احنا لينا طلب عند حضرتك ان دي ما تبقاش اول واخر برزنتيشن، وان يبقى في لقاءات تانية مع حضرتك في الشهور الجايه ان شاء الله.
من عيوني ابدا. تامر.
شكرا دكتور بروفيسور ناصر، شكرا بروفيسور خالد، شكرا دكتوره زهره، تعبناكم معانا.
شكرا.
تحت امرك يا دكتور ابراهيم، صباح الخير.
امرك يا ابو خليل، على راسي. وطبعا دكتور ناصر ده اخويا الكبير يعني، وهو عارف يعني ان هو يعني هو سعودي بهوى مصر.
عزيز والدي يا رجل. والدي عاش ودرس في مصر واغلب اصدقائي.
الله يخليك الله يخليك.
احنا سعداء جدا بوجودك معانا دكتور ناصر. شاكرين لحضرتك جدا.
شاكرين جدا.
نتقابل قريب ان شاء الله في ميتينجز قريبه، وان شاء الله تبقى معانا كمان في الزومز اللي جاي ان شاء الله.
ان شاء الله.
شكرا دكتور ناصر، شكرا دكتور خالد،
شكرا دكتور ابراهيم.
تعبناك يا زهره معانا.
لا مش تعب ولا اي حاجه.
شكرا جزيلا، مع الف سلامه.